a review of the Canadian healthcare system for many who aren't familiar with it. And I find that most Americans aren't really familiar with it because they don't live it every day. And if you don't live something every day, you don't really understand it, and you don't even ask the right questions.
Right. Okay, fine.
Okay, okay. From current slide, does everybody see the presentation that's up?
Yeah.
Yes.
Okay. So thanks, Mike. And Mike's asked me to come on and give this presentation just about the uh, state of the Canadian healthcare system. And I'm going to do this in two parts, I think. I'll give you a quick overview using some slides uh, that get us all on the same page of how the Canadian Medicare system works, and then I'll dive into what's really going on right now and where I think it's headed. I think you should probably find this pretty interesting because as you go, you'll be able to sort of apply and relate where there are similarities and differences between the Canadian American systems. And I'll make it clear as we go with some comparisons. So we'll jump right into the basics here. Um, so the you I'm just going to go with the first item there, and you know how often we hear the term single payer in the United States. Well, Canadians don't really use that term. They just call the system Medicare, and most of them wouldn't know what single payer was if you said it to them. Although many know it's a single payer system, they just call it Medicare. Um, the whole system was built on a pretty straightforward idea. If you're a Canadian citizen, you should be able to get the health care you need. And it doesn't matter whether you're rich or poor, everyone gets access to the same services. Um, it's paid for through tax revenue, but not entirely the way you might think. The provincial governments think of them as the states. They're actually carrying most of the weight, and they're covering about 78% of the costs. The federal government chips in the other 22%. And um, unlike some other countries, they don't take money from paychecks or employers. So there's no special healthcare tax on your employment income, or neither is there any tax taken off the employer. Okay, so let's set the record straight on inaccuracies because there's just a lot of nonsense floating around about the Canadian healthcare system that isn't true. First of all, there are actually 13 different systems, one for each province and territory that all meet standardized guidelines. But there's 15 if you count the military and veterans care. But Canadians just really call it Medicare because it covers the same stuff. Historically, Canadians have had universal hospital care since 1948, and that's the same year that the UK's National Health Service, NHS, was started. And back then it was just called, simply hospitalization. But the term Medicare, which was coined by Tommy Douglas, kicked off in Saskatchewan actually in 1961. They were the first province to do that. And then with the federal government on board, it took until 1974 for every province to actually get into the program. Um, I just want to mention this because it was crazy when I first heard this. I couldn't believe it. And it's what Canadians most scratch their heads about when they hear about the U.S. system and the whole concept of pre-existing conditions and why that should even be a thing. People are sick and they need care, right? What's wrong with doing that? And Canadians don't have different types of plans. They just have healthcare. Healthcare is healthcare, period. Doctors set the standards, not the insurance companies, and you'll see the consequences of that in a couple of slides. Paperwork. Unless you're getting a prescription filled or a sick note from your doctor, you'll never see a medical bill or some other kind of form, and that's for your entire life. Um, Something else that might surprise you is that most Canadian healthcare actually comes from the private sector. So family doctors are mostly running their own small businesses. And speaking of the family doctors, they're trained to do a lot more in Canada than in the United States. They have 30 subspecialties, including anesthesia, geriatric care, physiotherapy, emergency medicine, and so on. Those things would be the private domain of specialists in United States, but in Canada, it certainly keeps interesting things interesting for family doctors to do all these subspecialties. And my best friend actually he's a family medicine practitioner, but he's worked for the last 30 years as a anesthesiologist. So here's Tommy Douglas. He's basically the father of Canadian Medicare, but Americans would appreciate that he's also Donald Sutherland's grandfather and or father-in-law and Kiefer Sutherland's grandfather. Um, he's he's given the most of the credit for establishing the five key principles that really form the foundation of the Canadian healthcare system, and you see them there. And these aren't just guidelines, okay? They're not just words; they're actually written into the Canada Health Act, and they're pretty straightforward. Canadian healthcare has to be publicly run. It needs to cover all necessary medical services. Every Canadian gets the same coverage. They can access their healthcare anywhere in Canada, and everybody needs to have access when they need it. So here's really the game changer between Canadian and American healthcare. It comes down to who calls the shots. In Canada, it's pretty simple. Doctors make medical decisions, period. The paperwork that follows, that's just internal bookkeeping. But in the States, it's a whole different story. Insurance companies have their fingers in every decision because it's their fiduciary duty to maximize profits for the company and its shareholders. They're the ones determining what's necessary and what's covered. And that automatically means you'll need special permission before getting treatment. And everybody's probably familiar with those telephone calls and text messages. So think about it in this way: if you're in Canada, if your doctor says you need something, you get it. In the U.S., your doctor might say you need something, but then there's a whole other layer of people in offices deciding whether they agree or not, and it's never clear why they might disagree. So that's a pretty big difference. Okay, now this slide really tells a story. I like to say that a picture is worth a thousand words. When you look at these two flowcharts side by side, it's really almost comical. Um, if you look at this whole thing is how uh, claims are adjudicated in either country. And if you look at the Canadian side, it's just refreshingly simple. Your doctor decides what you need based on standard medical practice, sends a bill to the health authority, and bang, um, that bill gets paid every 2 weeks to that doctor. They don't have to jump through hoops and they don't have to prove what they did and they don't have to get approval from the health authority. But on the American side, what we've got looks like some sort of Rube Goldberg machine of healthcare decisions. You've got boxes with decision arrows going everywhere, layers upon layers of people who need to sign off, rules, algorithms, checkpoints, roadblocks, decisions, where sometimes denied care is a default position for some companies. Honestly, it's enough to make your head spin. But the real world consequences for that Rube Goldberg mess over there are that it takes about $1 trillion of a $4 trillion system that is administrative costs. And if you think about it, it's basically millions of people digging holes and filling them up again because it provides absolutely nothing to do with healthcare. And this might be the clearest comparison picture I can show you how these two systems work in real life. One looks like you need a PhD just to understand it. The other one, it's basically, well, doctor decides, bill gets paid. Um, Here's something really important to think about when we look at medical decision making in Canada versus the US. I debated whether to put this in, and then I decided to put it in Because before the Affordable Care Act, insurance companies essentially had all the power. They could deny coverage for pre-existing conditions. As we all know, cap your lifetime benefits, even cancel your policy if you got sick. Sure that some of you are all familiar with those things. And sure, your doctor could recommend treatment but that didn't mean much if your insurance company said no. So, with the possible changes in the ACA with the incoming administration, it's a reminder of what could happen if these protections go away. Um, and that's by not entrenching healthcare as a right and without constitutional healthcare protections in the United States, we might see a return to a system where insurance companies and not doctors have the final say in what care patients actually receive. And if you don't think that's a risk, look at what's happened with women's health care. And this really shows why Canada's system, where doctors make medical decisions based on patient needs rather than insurance rules, it's so fundamentally different. It's not just about who pays the bills; it's about who makes crucial decisions about your health care. So, talking about money, when the program first started back in the 70s, that's when Medicare first started back then. The division was split between the provinces and the federal government on a 50-50 basis. And over the years, the provinces took on a greater management of their healthcare systems in their province, and therefore a greater responsibility for the payment. Now it's the provinces who are doing the heavy lifting, covering about 78% from their tax revenue, and the feds chip in 22%. It's a big deal for provincial budgets, and we're talking of between 40 and 45% of every dollar they spend, and every one of those percentages is really important. And they get pretty creative about where they find the money too. Regular taxes for sure, but also lottery money, casino profits, even taxes on things like oil and gas. So in every province in Canada, except Alberta, you'll be paying pretty much what we pay in California for gas. It's pretty comparable, and that's probably mostly because of healthcare. So, some interesting twists on that. A few provinces have started asking their wealthiest residents to pay a special premium, and other provinces they've tied a small user fee to healthcare. But the important part of that is that no province can deny anyone healthcare for any reason, no matter what. So that's a line that no province can cross, even if somebody didn't pay their $25 a year premium. Um, the whole system is designed to spread the cost across society in different ways, but never in a way that blocks access to care. So some important points to consider. Uh, these also get to the heart of what differentiates Medicare from the American system. Though it's never been officially called a human right in Canada, the 1984 Canada Health Act actually made it one in practice. Um, Secondly, from the day you're born till the day you die, you are covered, period. There's no judgment about who deserves care. Everybody gets the same treatment. And um, something that might sound crazy if you're an American, once a practice is a standard of care and approved, the cost of the treatment never enters into a medical decision. Never. Uh, Doctors get to approve it, and the system doesn't question it. And as I've said before, Canadians don't have different levels of healthcare quality. There's no gold-plated or platinum-plated premium version. Healthcare is healthcare, period. Most Canadians have a family doctor who knows their history, and they don't pay a dime for their care. And as I've already said, and I'll say it again to reiterate it, the whole thing runs pretty on a pretty simple principle. You contribute through taxation, which is interesting. Canadians pay about the same as the American tax rate. We didn't see much of a difference when we moved here, except for the fact that we didn't have health care with our for paying all of our taxes. And as I said before, it's never collected through employment contribution. So Canadians are free to move to any job they want and never lose their health care. So the Canadian government's first phase, this is really new. The first phase of national pharmacare introduced through Bill C-64 in 2024, late 24, focuses initially on providing universal coverage for contraceptives and diabetes medications. This targeted approach aims to help 9 million Canadians right now of reproductive age, and also 3.7 million Canadians with diabetes afford their essential medications. And the program is overseen by a newly created agency, which is called the Canadian Drug Agency. This is a first step, really, in a broader vision to make prescription medications affordable or accessible to all Canadians, regardless of where they live or their ability to pay. So, come next year, early in 2025, a panel is going to hand over the game plan for the full national pharmacare rollout uh, by the feds. And this is the blueprint for how Canada is planning to grow the program from just diabetes and birth control to their plan to cover all necessary medications for every Canadian. And the health minister is going to use these recommendations to map out the next steps. Likewise, the Canadian Dental Plan, which was just launched last month, um, and it's rolling out comprehensive dental coverage to select eligible Canadians right now, starting with seniors. That's most of us here, persons with disabilities, children under 18, and those with limited income. And by limited income, it's any individual earning less than $70,000 gets free dental care, and every family earning under $90,000 total income gets free dental care, comprehensive, everything. And this will be expanded in the coming years with no timetable established yet. Um, and I think this is interesting to Americans. It's actually a very important way to transform preventative health care, um, if you think about it. So when people can't afford basic dental care, small problems become big ones. As many of you are doctors on this call, you know that cavity that could have been filled turns into a root canal, or it comes an infection that impacts overall health. And by covering seniors, kids under 18, and the working poor, Canada's protecting certainly their most vulnerable populations. And for seniors, it means they won't have to choose between paying for dental care and groceries. For kids, it means establishing good dental health early, which sets them up for better health care throughout their lives. And the really smart part of that is by focusing on prevention and early treatment, there will be fewer emergency room visits for dental problems, and that means less need for expensive procedures down the road and better overall health outcomes. And as we know, good dental health links to better heart health, better diabetes management, and fewer complications during pregnancy. So it's time the teeth got put back in the body, and because it's about whole body health, not just tooth health. So this slide is about the evolution of Canada's healthcare system in a timeline. Uh, Post-war, 1948, the intentions for comprehensive universal healthcare were kicked off with the hospital construction grants program. Basically, the federal government was helping the provinces to build hospitals where they were needed in any part of their province. By 1957, they took another big step with the Hospital Insurance Act, and that made sure that Canadians could get hospital care without having to pay a dime. And the 60s were really when things started to ramp up for for healthcare in Canada. Tommy Douglas, the Premier of Saskatchewan, started in 61 in his home province by bringing the doctors under the single payer system by 1964. And then Ottawa, the federal government, followed suit nationally with the Health Resources Fund Act of 1966, which offered to reimburse or cost share one half of provincial costs for medical services provided by a doctor outside of the hospitals. And then 1968's Medical Care Act was the game changer that finally introduced universal Medicare coverage, or what Canadians now call Medicare. And in 1977, under the Provincial Fiscal Arrangements and Established Programs Financing Act, a big name, must have a better acronym than that, but cost sharing was replaced by block funding. And that was a combination of cash payments and tax points for provinces. Complicated, and I won't go into it now. Then finally in 1984, Canadians got the Canada Health Act, which is really their healthcare constitution and basically establishes the right to healthcare for every Canadian by setting those five big principles we saw earlier, Tommy Douglas's five big principles that make the system uniquely Canadian. And despite the shortfalls to other services in 2024, Canadians now are adding two major additions to their healthcare legacy: pharmacare and the dental care plan. Both of those are in the rollout phases, as I said, and they've targeted specific groups first. So rather than, although the system has problems, rather than abandoning the healthcare principles, Canadians are still building on that foundation that was laid over 75 years ago. But let's be realistic about what is happening with Canadian healthcare right now. The numbers actually tell a pretty troubling story. About 6.5 million Canadians, that's more than 1 in 5 Canadians, don't have a family doctor right now. And the real problem with using emergency rooms as primary care, ERs are designed for acute crisis management. They're not equipped to handle ongoing health issues, as everybody knows. When patients can only access healthcare through emergency departments, they're getting disconnected care, episodic care for what might be complex chronic conditions. As an example, think about a patient with diabetes that has to access their care through the ER or urgent care. Without a family doctor, they will end up in the ER when their blood sugar spikes dangerously high. And the ER team, yeah, they stabilize them. They're prepared to do that. But who's monitoring their A1C levels month to month? Who's checking their kidney function? Who's coordinating with an endocrinologist if they need one? Emergency departments simply aren't set up for this kind of long-term care management. Even worse, these patients, they fall through the cracks when it comes to preventive care and regular screenings. By the time they show up the ER, what might have been a manageable condition has often become a serious medical crisis. It's not only dangerous for the patient, but it puts enormous strain on emergency departments, which are already overwhelmed with actual emergencies. And the final critical point: in emergency medicine, there's no continuity of care. No one tracking the patient's overall health picture, no one advocating for the patient within the system, and no one knows the patient's full medical history. That's not just inefficient, it's dangerous for the patients. COVID didn't create these problems. It just shone a spotlight on how fragile the Canadian primary care system had become. And we've had countless reports and recommendations on how to fix things, but they're mostly sitting on shelves gathering dust. The Canadians are adding dental care and prescription coverage, and that's important. But it's kind of like putting new tires on a car with an engine that needs a rebuild. The system needs serious attention. Things have gotten bad when Canadians who used to brag about their healthcare system only 5 years ago are now totally ashamed of it. The truth is, we've gone from showing other countries how universal healthcare should work to struggling to provide basic care for people. that's a tough pill to swallow, but acknowledging the problem is the first step to fixing it. Um, so let me break down why fixing Canada's healthcare system isn't as simple as throwing money at it. We're facing multiple challenges that all feed into one another. First, there's a perfect storm of funding issues right now. The provinces are stretched thin, and while the feds can help, there are limits to what they can do. Uh, but the thing is, even if Canadians had unlimited money tomorrow, there would still be problems because they're desperately short on healthcare workers across the board. And this means doctors, nurses, specialists, technicians, and more are actually burning out or retiring than being replaced. They just can't train quickly enough because medical schools and residency programs can only handle so many. And even where they have trained more healthcare workers, they don't want to work in remote areas where they're desperately needed. Um, Meanwhile, Canada's healthcare infrastructure isn't keeping pace either. They need more hospital beds, more operating rooms, more diagnostic equipment, and all this is happening inside an aging population, which means more healthcare services are required just when there are fewer working taxpayers to fund them. We may have the same problem here in the US very shortly. But here's what's really frustrating. It's been frustrating for me personally, is that there have been policy experts telling everyone that this day was going to come and how to plan for it and fix these problems for decades. There are reports, recommendations, proven solutions, but they've almost been completely ignored. It's like we had the repair manual all along, but nobody's even opened it to follow the instructions. So when we talk about fixing Canadian healthcare, we need to understand that it's not just one thing that needs fixing. It's a whole interconnected system that needs rebuilding on the fly. So I've spent a lot of time analyzing what it would take to really transform Canadian healthcare. And while there are probably dozens of factors we could discuss, I believe these key points capture the most critical elements for meaningful change. This is a roadmap for the United States too. So these principles apply everywhere. We're not talking about band-aid solutions. These are fundamental changes that could reshape the Canadian healthcare system. And the first up is equity, top of the list. And I mean real equity, not just saying everyone has access. Whether it's here in the US, we need to think about healthcare the way we think about public education. Just like every neighborhood has a school, every community and every member of that community needs a medical home. This isn't just a clinic, it's a healthcare hub where teams of providers work together um, uh, for care continuity in their community. Um, the team approach is absolutely critical in achieving this. Here in the US, the best example of this here in California anyway is Kaiser, but that only really covers its members, right? When we attach patients to an entire healthcare system, healthcare team, I mean, instead of just one doctor, we multiply the resources available. The patient might see a nurse practitioner one day, family doctor the next, a mental health counselor the next week, a specialist after that, and they all coordinate the patient's care together. The primary care provider, the family doctor, is the quarterback in all this. And there's also another uh, factor that's been adopted by the Kaiser model, but available for so few. We need to change how we pay primary care doctors. Uh, the fee for service model isn't working. Moving to salaries or shifts means doctors can focus on patient care instead of rushing through appointments to keep the lights on. I can tell you stories about how some unscrupulous Canadian doctors have put through 75 patients in a day, but that is uh, that in a way they're working to save the system, but they're not really saving anything. They're not really treating the patient if they're putting through so many. And we've got to think regionally. Having top-notch facilities in urban centers doesn't help if there are healthcare deserts in rural areas, and this goes for rural Canada, and especially northern sparsely settled regions, which is about 80% of the Canadian landmass, if you think about it. Canada needs to plan services across entire regions, partnering with communities to make sure everyone has access to the care they need. And finally, this all needs to be backed by real accountability and measuring outcomes, not just counting visits. It's about building a system that works for everyone, not just those who have figured out how to navigate it best. But right now, Canada is a long way from access to team-based care for the entire country. They've achieved it in some regions, but to get that, they first really must establish a national standard for primary health care that doesn't yet exist. Individual doctors or even medical groups can't take on health of the entire population as they're responsible any more than an individual school teacher could be expected to keep adding students to their classroom as the population of that community grows. Can all this be done? Absolutely. But leadership has to have a vision. And the first step to fixing it is not unlike an alcoholic admitting they have a problem. After the assault on the system by the pandemic, political leaders hoped that Canada's healthcare system would simply spring back into recovery mode. But that hasn't happened. And hope is not a strategy. Unless some real work is done on the system, the cracks are going to widen and widen considerably. A report from StatsCan, that's Statistics Canada, an agency that keeps track, projects Canada's population could reach 50 million by 2043 and 74 million by 2068, even under a medium growth scenario. So currently 19% of Canadians are 65 or older, but this will increase to 26% by 2068. There's absolutely no plan in place to meet these challenges, and Canadians will need unprecedented healthcare reforms, even to begin to manage the growth that's going to occur. The answer lies in first reforming primary care, because all of the evidence points to a strong primary care system as the most affordable and fastest way for a system to recover. The first part of the solution starts by giving everyone a medical home and a long-term relationship with their care providers. And with that, I'll stop it here and open it up for questions. Mike, are you there? You're muted.
Yeah. Thanks, Henry. I don't know if you can turn on your spotlight. Right now you have sort of a blank screen, and then unshare. Then we can open up for questions.
Okay. I have a couple of other screens that were based on some of the questions you wanted to ask. So maybe I'll just keep it on. I don't have a camera today, so I'm sorry I won't be seen.
All right. Well, I will show everybody who you are. This is Henry. If you didn't see him in the ad. Okay.
Where am I?
Back. Well, let's see. Can you see it now?
I don't see anything.
Or now?
I don't see anything.
Oh, okay. Can everybody else see Henry's picture?
Yes.
Yes.
Okay. Some can, and they saw it in the invitation. So
my hair is more gray.
Okay. Yeah,
he's 10 years old.
He's down there living a few miles from Don McCann, actually, in Southern California.
That's right. I've been to Don McCann's place.
Yeah. So I'll stop share, and you can reshare if you wish. And then, but I would like to keep. There we go. I can see who's got their hand up. It looks like Lynn Heidekoper first, and then Corrine. for Joni. Lynn?
Yes, so interesting to hear what's happening in Canada. Two things. I don't know if you're aware of this, but insurance companies in America are starting to drop their patients in huge numbers. And that's a big problem here. So they have to find totally different doctors. So I'm sure that doesn't happen in Canada. I just got off a meeting. Phil Brewer from PNHP Connecticut talked about the PNHP conference where moral injury was brought up. And there are thousands of American doctors leaving the profession because of moral injury. That probably doesn't happen at all in Canada. Is that right?
Well, I guess you should define moral injury for me.
It's for doctors, we're insurance companies, they're making all the decisions. And, they, especially this, that's the reason that this guy was shot in New York was pre-existing conditions and patients constantly being refused services. And the doctors are frustrated because their patients can't get. And then was that you that talked about 30% of people can't afford their prescriptions in America? And maybe
Not
that
me,
was that
not
was
me,
the
but
previous meeting.
yeah.
30% of patients in America cannot fill the prescriptions their doctor has written for them. So that's kind of what moral injury is. I had to look it up too because I wasn't familiar. But it's
Yeah.
based that
Yeah, that's not a situation that a Canadian doctor would ever have to worry about. Canadian doctors burn out and they retire. The average age of Canadian doctor in Ontario, I think right now is 60 years old. So that's told us right now that they're just not graduating enough doctors from medical schools. In addition to that, there are 13,000 doctors from other countries who have graduated and some have practiced. They're in Canada as immigrants, and they simply don't ever get hired because they don't ever get to do a residency. There just isn't the room for them. So there's a real disparity right now that exists between what can be done and what is being done. And the doctors, if they wanted to come up with some breakthrough ways of getting them residencies, they really wouldn't have to graduate that many more doctors. The doctors already exist as immigrants in the country. We call them FMGs in the United States. They're called IMGs, international medical grads in Canada. But no, for moral injury, no, a doctor would never have to, because the doctors make the decisions. A doctor would never have their 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 medical decision questioned by the healthcare authority in their province. It just doesn't happen.
Then, thanks, Henry. Corrine, you have a question?
Yes, I do. Just for clarification, or addition, PNHP is starting a project to explore moral injury in physicians in the United States because there's a lot of problems with moral injury going on, and it does lead to burnout, which is the physical and emotional consequence of moral injury for some. But should be a very interesting project that PNHP is starting. But I missed it if you said anything about tuition for medical school, how much it costs to become a doctor. I'm not sure. I might have missed it. But the other question I have is your reference to getting rid of fee-for-service and also for accountability, because that is the buzzword these days. It's called value-based payment programs. And believe me, it is a nightmare because what has happened is that physicians are now getting bonuses or losing money. They're assuming the insurance risk because they have to produce data points that show that they're meeting certain metrics. So in the United States, we have teachers who have to teach to the metric, and that's what's happening in healthcare, that doctors are now having to treat to a metric. And so I'm wondering, when you talk about accountability, whether it's the individual physician that has to come up with all the points, meeting certain points, or whether it's population-based accountability, which certainly makes a whole lot more sense to me.
Well, going back to your first question about tuition, my daughter is she's an internal medicine specialist and she ran the COVID ward at the big teaching hospital in Winnipeg over the last several years. And she is strictly a hospitalist. So she gets paid a salary. She gets paid based on her qualifications, not how many people she sees, and she's able to work the hours. She works 12-hour shifts, 4 12s, I think, and then 3 days off, and she basically takes off her own time for vacations and so on. So she's worked it, so she gets people to cover for weekends and so on. And I think that's the profile of a young doctor these days. She's about 35 years old, and she is pretty typical. Young doctors don't want to have to work fee for service. They don't want to have to open their own businesses. They don't want to have to work weekends and be on call 24 hours a day with patients knowing their telephone numbers. They want a life like anybody else. They want to be able to raise their kids and not have to rush away from a soccer game uh, or a hockey practice to treat a patient. That's they want to have a normal life. They got all that grief during their residency, right? Just like you did, Corinne.
Yeah, and I've always had a salaried position, but I
Well,
do
there you go.
believe
But you
the
you know what I'm
right.
talking about with your
Yeah,
residency
but
because
then I lost autonomy when I
yeah,
had my salaried position in because there were decisions made that affected who would be my medical assistants, a lot of things that you don't have to deal with in private practice. Certainly
yeah.
business model in this country would be enormously complicated, which
It,
is
it
why
yeah,
it's
it's a
salaried. But
trade-off,
I
but
think it needs a mix.
yeah, it's no different. There are the groups. Ontario has had a long history since 1990. They've been using these medical groups, care groups, and the team approach to. They've almost done away with fee for service in Ontario and province of Ontario, which is Canada's biggest province, and they've gone to a team approach where they pay the doctors, but it's not no longer a fee for service system there, and I think doctors mostly like it. Um, but again, comparing what doctors do in Canada to the United States is almost an apples to oranges comparison.
Good.
Can you answer
Thanks.
the question about
The,
accountability?
yeah, by the way, the tuition fees, I think for Rachel were under $100,000 in total, and she was able to work most of that off with her job. She paid for her tuition by the time she graduated as an internal medicine specialist, so she had no debt. And that would be like unheard of in the United States.
Good. And then there was one more question, Corinne.
About accountability.
Yeah, right.
When you referred to accountability, and I told you what's going on in the United States about the pseudo accountability, I'm wondering if you're talking about individual physicians' accountability, or and how you would set that as a standard and make physicians accountable, or whether you're talking about population accountability, health.
Yeah, I'm talking about health accountability, not individual physician accountability. That
Okay,
that
yeah,
that could
that
be
makes a lot more
that
sense.
that could be something we could discuss on another call. I would like to hear more about that and make a comparison study of that. That's interesting to me.
Thanks. Next is Kendall, and then Diane, and then Sylvia.
I have heard rumors that for-profit entities is trying to destroy the system. Is there any truth to that?
For-profit entities? No, I don't think so. I think that the entities that have started for profit, a lot of them have been necessary. There was uh, the the guys, the Dr. Day, I think in Vancouver, he started a private hospital and he sued the government. He wanted to have a full service hospital with overnight stays and so on. They wouldn't allow that. But he was when he was doing this lawsuit, which lasted for 10 years or longer, his hospital was already full of patients. He had doctors from all over Canada who had retired in BC because that's where they go to retire. And he had his pick of specialists, and he did very, very well because he was handling workers' comp cases, and the government was giving him, even though he was suing them, they were giving him all kinds of work. There was never a minute where he had to worry about his hospital closing down. So yeah, a lot of some doctors have had, on their individual initiative, they've started a project like opened up an MRI facility where it's needed. There wasn't an MRI, and then the government tried to shut them down for a little while, and then they started giving them started giving them work, you know. And everyone that I'm aware of now is actually working with the government because Canada just doesn't have the capacity that Orange County has more capacity than the entire country of Canada, I think. I dislocated my shoulder in a fall off a mountain, and I went into the emergency room here at Memorial Hospital. And in the middle of the day, I was the only person in the emergency room. And I thought, what, what kind of system is this? In Canada, they would be in the hallways on stretchers, and every seat would be full, and I was actually the only person in there, and I just thought, wow, what a difference. Any other questions?
Yeah, let's see. Mike is muted. This is Chuck. Henry, welcome.
Hey, Chuck, how you doing?
I'm fine, brother. Appreciate you doing this.
Yeah.
Let's see. We've got Diane and then Sylvia, who have their hands raised, and then we're going to jump over to the chat. And there are several questions in there, so let's go that direction. Diane and then Sylvia. Thanks, Henry.
We used to be told that 96% of Canadians love their Medicare, and I wonder what that figure might be nowadays. And also, I was wondering about the expensive drugs which are sold here by direct advertising from the drug company to patients on via TV and internet and so on, and whether Canadians see that advertising and request those drugs, and if so, what kinds of strains is it putting on the system?
Okay, your first question was
96%.
if I had to I would drop the 9 off there right now, and I would give it a 6%.
6%.
I don't know. I don't know, but the dissatisfaction is extremely high. It in my home province. It upset it was the reason why the government lost the last election. The new government came in and he promised to fix healthcare within 2 years. It's been 2 years since he got a mandate, and it's gotten worse. So it's always been said that you will lose an election if you don't take care of healthcare in your country. And Trudeau is going to lose the next election big time because he has not taken care of healthcare, and that's probably the biggest reason why a Canadian politician would lose an election. So the satisfaction where at one time It was very high. It is it is desperately low right now. Let's put it that way.
Mhm.
And as far as advertising goes, it's I have a theory about why drug companies advertise. My theory is that drug companies continue to seed news items into the news that aren't true. They keep talking about breakthrough treatments for a lot of neurological diseases like MS, ALS, Parkinson's disease, and so on. These are rising almost at an exponential rate around the world, and a lot of that has to do with an aging population because they're age-related chronic diseases. But uh, they they keep on coming up with new drugs to treat them. The drugs are highly ineffective, but the FDA now has a very low bar. And so if the drug doesn't kill anybody and it's minimally effective, or they can prove some sort of minimal effect on the disease against the disease, then it'll be licensed and it'll be sold for $100,000 a pop. So they keep seeding in these if you've ever noticed on the news, they'll have they'll talk about a drug and the possibilities of a drug that they're going to be introducing, and they'll have some patient that has recovered fully from it, and that's I think the trade-off between paying the media companies, CBS, NBC, ABC, the big networks to advertise when every doctor you talk to says they're not influenced by the advertising. I've never met a doctor who says they're influenced by the advertising, and they'll say that patients can't come and demand drugs. So why do they do it? And I think they do it specifically for the promotion of the drugs that they've got in the pipeline down the road. And do Canadians see them? Yeah, of course Canadians see those ads. But some of those drugs aren't even available in Canada yet. And for a lot of the diseases, chronic diseases, the very, very expensive diseases like cystic fibrosis. If you're Canadian with cystic fibrosis, you're getting all your meds paid for. If you've got MS, you're getting your meds paid for. If you've got expensive a chronic disease that needs these drugs, you're getting your meds paid for by some government program. So it's a question of whether the Canadian government, and there's all of these. This is Canada's health portfolios, and all those drugs have to pass these panels before they're approved. So it takes a while. FDA
It's
usually
not
approves
really,
something, and
not
then
really
and then a
stressing your
couple of years
system.
later, Health Canada will approve them, but they have to pass a muster through all of these particular agencies.
So it's not really stressing your system.
No,
Good.
no, very, very in a very limited way, and
Thank-
a lot of these drugs for orphan diseases, yeah, they cost a lot of money, but they're so little in the total expense of the system that they approve them anyway. So the drugs that would be approved in the United States are generally approved in Canada a couple of years later.
Thanks, Diane. Next up is Sylvia, and then we'll jump over to the chat. Sylvia?
Okay, thank you, Henry. First of all, this is really important. As a retired nurse practitioner, a couple things. I thought the United States was the only country that allowed prescription drugs to be advertised on television. So I wondered, does Canada forbid it? That's number one. And imagine advertising chemotherapy, like a patient's going to come in and tell their doctor which chemo they want. It's outrageous. The other thing is, does Canada use nurse practitioners and physician assistants like the United States does?
Absolutely. PAs and NPs are used almost as frequently in Canada as doctors are. Yeah, and the problem is they don't graduate enough of them now, and it's the same problem. There just aren't enough in the system right now.
And is it legal? Thank you. Is it legal to advertise prescription drugs in
Nope.
Canada?
Yeah, United States and New Zealand are the only two countries in the world where it's legal to advertise drugs on in the media. But Canadians get all of the channels. So I mean, you're watching a Canadian channel and you flip over to watch the football game, and you're watching, Minnesota Vikings playing Philadelphia Eagles, and you're getting all the drug commercials, or you're watching MSNBC. Canadians watch the same programs as Americans do, and they get all those drug commercials, but they really don't mean anything in Canada. They're just there.
Thank you.
Thanks, Sylvia. Okay. All right, Henry, you're good with time right now?
Yep, I got about 15 minutes.
15. Okay, let's zip through the chat here. Mindy from Ohio asked, have you heard if someone wants to move from the US to Canada? They cannot if they have pre-existing condition. Is that true?
The Canada, well, if you marry somebody, you can get across that way. It doesn't matter if you got a pre-existing condition or not. If you're an immigrant, you immigrate to Canada based on a point system, and the point system includes your education, the state of your health, and so on. So yeah, I could see that you would, unless you actually married a Canadian, you're not going to get in to Canada if you immigrate with a pre-existing condition, and that's true. But and I never even thought of that before, Chuck. But that's the only place where a pre-existing condition would mean anything to the Canadian government. Yeah.
Right. Thanks, Mindy. Thanks, Henry. Let's see. Catherine asked, I heard Canada wanted us to get expanded and improved Medicare for all so that you all would have an easier time getting dental coverage. Looks like you didn't need us to help you. Is that a question, Catherine? I guess that just let's keep going. Do you find for-profit entities trying to destroy the system? I think that question was asked by Kendall. Let's see. Could it take a little bit? Can you talk a little bit about the Medical Aid in Dying Act Canada recently enacted? This is from Cheryl in Corvallis, Oregon. The
Yeah.
Medical Aid in Dying Act.
Yeah. We've been talking about that in our men's group lately here in the United States, but it's been in my home province. It's been around for about 10 years now, and my sister-in-law actually went through it. She was helped. She had a really bad fibrotic condition in her lungs, and it was a disease that there weren't any drugs, there weren't any things. And she wasn't a candidate for a lung transplant because she became too frail. Um, um, Otherwise, they probably would have transplanted her had she even got on the list. But I guess it came upon her so fast that and she was over 60, so it was a problem. So she elected to go through the MAID program, the Medical Assistance in Dying program, and I wasn't there. She did that 2 years ago, but my niece and nephew say it was one of the most beautiful experiences. They had a team come into their home, and they did everything in the home, and they had several meetings with them, and it was just really, really humane. I understand it's not that same way in California, at least, but because they actually make the patient, they give them the uh, the power to inject themselves after they set it up for the patient. So the patient has to do it themselves without the help of any medical practitioner, I think. But no, they've got a team that the MAID team in Canada does that, and it's been around for a while, and it's working very effectively. I don't think any of the problems of people that they said was going to occur of people just offing themselves because they didn't want to be here anymore. That wasn't the case. My sister-in-law was in real distress. she day by day she couldn't get enough air, to for her body to function, and she would have died within a month or two anyway. So it was the humane way to go. That's what I know of MAID in Canada.
Okay, thank you for that, Henry, and the question. Cheryl, I think another question, I think you touched on this a little, Henry. There's quite a variation among the provinces, and this is what you said, 78% is picked up by the provinces, healthcare costs. Can you tell us which is the most stressed right now and which is the least stressed overall?
What do you mean?
I
Which
imagine which of the
is
provinces is doing best and worst.
oh it's hard to say. I don't think any province is doing particularly well. I think Alberta might be doing the best. They've got the most funding, but the problem is really a lack of people, lack of professionals, lack of doctors, lack of nurses. It's systemic.
Mhm.
It's a problem everywhere. Yeah, so some provinces are doing better. I think BC isn't doing particularly well. Alberta is doing better. Manitoba, my own province, is doing very poorly. Um, so I my best friend, who's a physician, he was just here last week, and he told me that, and he's family practice, but he makes most of his money doing anesthesiology. But he says he doesn't feel like he's treating patients anymore. He says he's treating the system, and that is a problem when you feel that you can't spend enough time with your patients. You're just
Right.
expected to put them through the system.
Right, right. And with that in mind, are there some resources that you might point people to find out more about what's going on in Canada?
Um, Other than my presentation,
Good point. Yeah, you got it nailed. But yeah, I mean,
somebody sent me this today
yeah,
here, and it's
where do you go for your research?
I go to CMAJ, Canadian Medical Association Journal. I go to the news items because I link these with how many patients are going to the from Canada to the United States. But I went and I looked, and uh, uh, you know Canadian provinces have always had arrangements with American hospitals. That's not nothing new. For example, in my own province, there's a string of towns along the Canadian border, in it right next to Minnesota. So there's thousands of people that live there, and the closest hospital is 120 miles away in Winnipeg, or they can go 2 miles across the border to Roseau, Minnesota, and so they've turned Roseau essentially into a Canadian hospital. And so the ambulances go across the border. They do life flights, medical pickups from Roseau, take them into Winnipeg. It's almost like the border doesn't exist. So there's places along the Canadian border where just by common geography, you're going to have these cross-border arrangements, no different than going across from one state into another, Kansas City, for example. But yeah, these things, just because the pandemic happened, and there's now 600 BC residents going to the U.S. for cancer care, it doesn't mean there weren't always 400 residents going across. It's always happened. There's always been these cross-border agreements that they've had with other medical facilities in the United States.
And so their provincial national coverage follows them into the United States as
Yep,
well?
absolutely. And they pay those hospitals as if they were from a single payer, as if they were a Canadian hospital and Canadian doctors.
Brilliant.
Absolutely, yeah.
Let's see, Patty Harvey of Humboldt, California asks, you may have done this earlier. I jumped in about half an hour late. Would you care to comment on the recent assassination of the United Health CO?
I don't know what I can say about that. I mean, how does everybody on this call feel about it? I don't have any. I feel sorry. I feel sorry for him. But if anybody says that they don't understand why somebody would be desperate enough to do something like that, I think that it's probably true that that there isn't a lot of sympathy for somebody who sits at the head of an organization that denies needed care to people for um, their health care, which is a life or death decision, and that's the truth of it. So I'm not going to sugarcoat it and say, oh, it's horrible. Nobody should be that desperate. I don't know if this person was that desperate, or whether he thought he was maybe somebody like Robin Hood. I found out a little bit about him today, that he came from a well-heeled Pennsylvania family that's involved in politics in the state, and uh,
Terrible.
that he comes from privilege and money. So I don't know what his particular uh, message was or what he was trying to do.
Yeah, yeah.
But I don't know. Maybe
Yeah.
somebody else has a different opinion than me.
I'm sure there's a ton of opinions in this room. Let's just keep going here.
Can I just pipe in real quickly?
No, actually, let me get through the chat, and your hand is up. I'll get to you, Lynn, after we just get through the chat, just respectfully, because Henry's got to cut out in 5 minutes. I would just want to make sure we get everybody covered first, who's not yet asked a question. Let's see. We got the U.S. and amongst countries where healthcare emigrate. No, it's a statement. There's a chat going back and forth between people. And that's awful. I think I got through all the chat questions. Did anybody else? Did I miss anybody in the chat? If not, go ahead, Lynn. Keep.
Well, just in following up on the death, about 45,000 people wrote in because of denial. And the manifesto of Luigi talks all about back pain. His mother had a lot of health issues and they were denied. So it does sound as personal. But Jeff, no, anyway, the guy in Connecticut said he was angry that the leadership of PNHP did not take this chance to talk about Medicare for all. And that one podcast that I watched talked about that. It looks like this would be the perfect time to address Medicare for all.
To that, I say, when isn't the perfect time to address Medicare for all?
Yeah, yeah.
Right, but that means you have 40,000 people captured right there.
Yeah.
Who are upset with the system.
Yeah. Well, it's true. I mean, it's timely, but it's almost I don't know. It almost seems like gallows type stuff when you take it up so quickly. I don't know.
Yeah.
Hank Gorheis may have a question or so.
Oh, I didn't
Hank?
see Hank.
Yeah.
Hi, thanks. Hey, so Henry,
Yeah.
a question. So, the main in Maine here, we've been, our medical association has a statement for healthcare reform. So one of the jobs I have is from the medical association, is try to understand what it's like to be a doc in a provincial Canadian system. So I've had some calls with docs that my friends, and also I talked to the medical director of the Regional Health Authority of New Brunswick, and of the head of the medical societies of New Brunswick and Nova Scotia. So when I tried to understand what it was like, I sort of came up with on the screen, I think is sort of and I want to bounce it off you, and also if there's any comments from any folks as to how it sells or something, or whether this makes sense, is like a power and prestige matrix, let's say.
Yeah,
And
I finally got that after I looked at it for a while. I
Oh.
did get it, but it was a different sort of perspective than what I was taking in mind.
Yeah. And let's say this is how it is now in the US, let's say, where, physicians feel powerless anyway, and hospitals, because they employ physicians, and insurance companies, let's say, are the power, and patients maybe are less on the power scheme too, because, of all the financial restrictions stuff. And Mike, why don't you just go ahead and advance it one slide, if you could? So, okay, maybe you skipped one, but that's okay.
I
So,
didn't put that in. I put this in my presentation, but you
oh,
had a bunch of stuff crossed out in the other one, and that's
yes,
why I didn't put it in because
okay.
I thought you were deleting it.
Perfect. No, actually, it was the idea is so let's say this is what I understand in the Canadian provincial. What's missing here is insurance companies.
Mhm.
They do not exist anywhere in the power, let's say in the Canadian in a provincial system. And at least what I try to describe is that patients move up in the power matrix, let's say, because they have freedom of choice and limited capped out of pocket, they're still taxpayers. But if they have a complaint, they complain to their member of parliament, who then complains to the Ministry of Health and says, "Hey, how come there's no OB services in Yarmouth, Nova Scotia?
Yep.
I want an OB doctor back there." Because who does a quote unquote a taxpayer or a citizen or a voter complain to is not to the insurance company, but to the member of parliament. So the
That
idea is,
that's right. But you
go ahead.
you're spitting into the wind when you're doing that as well. But it's uh, you know what? From my perspective here, after living here for over 10 years now in the United States, I I see what Canadians are doing wrong, and that is exactly what you mentioned. A grassroots citizens advocacy group for healthcare does not exist. And I cannot believe that there aren't these groups that are screaming to the heavens that there needs to be change. And I have no idea why they don't exist, other than you know the old joke: how do you get 10 Canadians out of a swimming pool? Just tell them to get out.
Okay.
You know, like
Yes.
you won't get any feedback or any
Yeah.
back
Yeah.
talk from them.
Yeah.
It's
Good.
just Canadians have been too compliant for too long,
Yeah.
and that needs to end.
Yeah. Good government and good citizenship. That's a Canadian, as opposed to American, who's a little bit different. So and then the question is with your daughter is to ask her if the physicians I talked to, at least the ones who'd had experience in the U.S., all said that they feel they basically just have to deal with the Ministry of Health and the Regional Health Authority, but seeing as how they're not employed by any of those entities, they feel that they are unionized and let's say they feel the physicians in Canada feel more quote powerful or empowered than the physicians in the United States, simply because they have that easier decision tree that you put up with the complicated, just the line chart you put up earlier about how the comparing the two. So I don't know. So does this make any sense? This is a rough draft. I made it up yesterday just as a say, hey, I wonder if Henry has any opinion or can get feedback or whether or not this sort of makes any sense. The power prestige matrix with the various entities, shall we say, in healthcare.
Yeah,
Patients,
I see where you're going with it. I don't see where it factors into it just states the way things are now, right? But
right?
I don't see where it might be useful in
Yes.
advocacy. It
Well,
just it's like the chart I put up with the adjudication chart, the one where you've got the Rube Goldberg thing and you've got the straight payment um, flow diagram there.
right.
But adjudication is so easy, and you don't have an insurance company. You've got a health authority who trusts the doctor, and they get paid based on a provincial code. You don't need all these ICD-10 codes, thousands and thousands of codes, because there's only about probably 200 or 300 in a provincial system that they're going to get paid on the basis of which they get paid, for doing those particular procedures.
Yeah, thanks, Hank.
Yep,
There are a
you
few
bet.
more questions. Henry, do you need to jump right now? It's 9:17.
Okay, one more
Oh,
if you would.
okay. So in the chat, let's see. We had what about patient accountability, good health practices? I worked for Kaiser. Patient accountability.
In which way?
This is
Patient to
Joanna's question, Joanna Stockslager. Joan, if you're with us, do you want to restate that? I worked for Kaiser. That issue was often discussed but never implemented. The notion of patient accountability, good health practices. So I guess, am I reading into this correctly, Joanna, that the patient needs to take responsibility for their own health and that there are
Yes.
consequences if they don't? Is that correct?
Oh, no, not so much that there's consequences, but I think one of the things that was happening with Kaiser when I left, and I think is happening more with Salem Kaiser now, is that making the patient more responsible for their portion of healthcare. I mean, I don't think we can ever have successful universal healthcare unless we take responsibility for our own health as much as we can. I mean, my husband has Parkinson's, and so obviously he didn't get that from his health practices, from his poor nutrition. He doesn't have poor nutrition. But in cases where there are instances where people do have something that is caused by poor health, is that discussed at all in Canada? I was just wondering.
And maybe woven into the education system as well?
Yeah,
Well, I don't know about that. I mean, we get the same Burger King commercials in Canada that you get in the
yeah,
United States, and fat, salt, sugar, fat, salt, sugar. I mean, we're bombarded with it all day long.
right.
If it's not a drug commercial, it's a sugar, salt, fat commercial. Lay our bodies. That's why half of us are morbidly obese. And laying off that is taking responsibility for that. But who's the government agency that is going to curtail those food recommendations or outlaw uh, burgers with French fries and fish and potatoes in them? I don't know. It seems so irresponsible to eat that way. But and that's what's causing all the obesity and the spike in diabetes in our society. What the answer is, it's not always you know access to health care. It is taking responsibility for your own health.
Yeah.
Yeah. Good.
Well,
good.
thank you for this presentation. Really excellent.
Yeah.
Okay,
Thank you.
well, I really appreciate you guys listening. I hope you learned something. If you want me to come back and discuss any particular part of it, just give me a day to bone up on it, and I'll come back.
Great to reconnect, Henry. Thank you so
Yeah,
much.
nice to talk to you, Chuck.
Yeah, absolutely. And I mean, just to say that, our focus at One Pair States, and we did put out a statement on that murder, and we really did encourage folks to get involved. But our vision is about healthcare and health justice for all, health. So the social determinants of health and so forth, housing, food, et cetera. So we do need to see them as all interconnected, absolutely. So I just want to double down on that point. And also, please, folks, consider this time of the year, especially to help us with donations. The work that we're doing here in DC is really critical. We want to elevate the state-based Universal Healthcare Act and get it introduced early in January. I'm working on getting the support of Ro Khanna, who's carrying the House bill, Ed Markey, who's carrying the Senate bill. And also on Thursday, I've been invited as a leader of a healthcare justice group to a briefing with Pramila Jayapal. The Medicare for All Political Action Committee's done some polling data, and they're going to just give us an early briefing. I'm not sure where it's going to go from there, but I will certainly get that information back out to you as soon as I learn what I learn.